Hi, my name is Amisha. I'm one of the Hem-Onc fellows, so I'm presenting at ASH 2024. So most of the patients receive ide-cel and cilta-cel for relapsed refractory multiple myeloma. Up until recently, it was approved after 4 lines of therapy, including the triple-class exposed patients. But most of the patients progress after receiving BCMA-directed CAR T-cell therapy, and we do not have good treatment strategies for patients who progress. So we decided to do this study. This is a single-center retrospective cohort study. Our primary objective was to identify the factors that were associated with worse outcomes after disease progression post-CAR T-cell therapy and the treatment strategies we would use in these patients. We had 106 patients who progressed after CAR T-cell therapy at Moffitt Cancer Center. 14 of these patients had early progression, that means they progressed less than 60 days, and 92 patients had late progression, that means they progressed more than 60 days after receiving CAR T-cell therapy. As you can see, most of the patients in our study population received ide-cel as compared to cilta-cel. That's just based on the availability of CAR T-cell therapy. We ran univariate analysis for progression-free survival and overall survival from the time of progression after CAR T, and we found that most of the factors associated with high-risk cytogenetics and high disease burden were associated with worse outcomes. If you look at this table here, out of 106 patients, 89 patients opted for first-line treatment, and this is the separation of the first-line treatment they received. Majority of patients ended up receiving combination therapy with alkylating agents, XPO inhibitors, BCL2 inhibitors. 29 received BCMA bispecifics, and 8 patients received GPRC5D. The results were pretty interesting. If we look at the univariate analysis for progression-free survival and overall survival, patients who received BCMA bispecifics or GPRC5D bispecifics or BCMA antibody drug conjugate, belantamab, had better outcomes as compared to combination therapy. However, there was no difference between the two bispecifics, maybe because we did not have enough number of patients who received GPRC5D bispecifics.